to travel, journey, voyage, expedition, tour, pilgrimage, safari, odyssey, to boldly go where no one has gone before.
Welcome to our podcast, Travel Unraveled, an ISTM podcast sponsored by the International Society of Travel Medicine and IAMAT, the International Association for Medical Assistance to Travelers.
So the deadliest animal on the planet isn't the shark or the lion or the snake. It's not even the human. It's the tiny, seemingly unassuming mosquito. And today on Travel Unraveled, an ISTM podcast, we're diving into the vital topic of arboviruses. What are arboviruses? Well, they're arthropod-borne viruses, including well-known diseases like dengue, Zika, and Chikungunya. Now, what's an arthropod? So the arthropods actually make up the largest phylum of the animal kingdom and include mosquitoes and ticks. And these are a critical focus for travel medicine. So today we're very excited as we talk to experts and review recent outbreaks and explore preventative strategies to help you stay healthy and informed as we break down these viruses, how they're spread, and symptoms to watch out for. So for today's episode, we are going to be having it hosted by Dr. Anne McCarthy and Dr. Sarah McGinnis. Hi, Anne. Hi, Sarah.
Hi, Aisha.
Hey, how are you, Aisha?
Where are you guys today?
I'm at home in Ottawa for a change.
And I'm at home in Melbourne.
Great. That's fantastic. So you guys will be hosting today's awesome episode. I'm going to hand it over to you to introduce our very exciting guests.
So we'll start by me introducing Dr. Ralph Huits, an infectious disease physician with extensive experience as a clinician in various areas of the world, including Asia, Sub-Saharan Africa, the Caribbean, and Europe. And he's a senior researcher at the Sacro don Calabria Hospital in Negrar, Italy, and co-principal investigator for the GeoSentinel surveillance network, where he is research lead. This is an emerging infectious disease network, which is a collaboration between the International Society of Travel Medicine and US CDC. Welcome, Ralph.
Thank you very much, Anne, for this kind introduction. And I'm already awed by the fact that you didn't stumble over those difficult vowels and combinations of letters that make up this introduction.
Yeah, welcome so much, Ralph. And I'd like to introduce our other guest today. That's Dr. Susan Hills, who originally hails from Australia. I'd like to claim that, but has been for many years a medical epidemiologist in the Arboviral Diseases branch at the US Centers for Disease Control and Prevention in Fort Collins in Colorado, which of course is in the United States. And she currently leads the US Advisory Committee on Immunization Practices working group that's drafting recommendations for the use of new chikungunya vaccines in the United States. So welcome so much, Susan.
Thank you very much, Sarah. It's a pleasure to be here.
Ralph, could you tell us about what exactly is dengue and why is it significant to travelers?
I think it's easiest to think of dengue as breakbone fever. It refers to a febrile illness where arthralgia, that is joint pains or muscle pains, are really on the forefront. It can also lead to fatigue and depression and anxiety and not well-being after the acute febrile illness. Dengue is caused by one of four related viruses. Yeah, we're still a little bit puzzled by what causes the natural course of infection to be either asymptomatic, that is completely without symptoms, or turn to febrile disease, or as happens in a minority of infected or affected patients, severe disease, bleeding, organ failure, and plasma leakage. That is, that these volumes of fluids and electrolytes are no longer contained within the vascular system. They start leaking out of it, and that leads to very, very dangerous situations, to critical illness.
It sounds like a disease you don't want to get, Ralph.
No, well, I can only from my personal experience tell you a little bit about it because I was in Asia working mainly as a student, and it was my first introduction to dengue. I was taken along with a pediatrician who took me to see the pediatric intensive care wards, and you'd see these children really suffering and fighting for their lives. Then fast forward around 2010, 2012, I worked in the Caribbean. I developed a rash. I developed a fever and a severe headache, and I got myself tested quite early. And my lab technician told me you already have antibodies to dengue, so it's very likely that I already had an asymptomatic bout of or infection with dengue, probably so many years before. And then I got symptomatic disease when I was working in Aruba.
I might switch now to asking Susan. So these are two diseases that have a bit in common. They're both viruses, they're both spread by mosquitoes. But how does chikungunya differ from dengue in terms of its symptoms and how it's spread?
Yeah, so the diseases actually can be quite difficult to differentiate based on their symptoms alone. So the symptoms of both can include fever and muscle aches and joint pains and headache and rash and feeling really tired. So you really do need a blood test to differentiate dengue and chikungunya and some of the other arboviral diseases like Zika that can also have similar symptoms. Having said that, joint pain does tend to be a more prominent feature of chikungunya. The joint pain typically occurs in the hands, the wrists, the feet, the ankles, but it can occur in any joint, including, in the neck, the spine, etc. And it can just interfere with normal activities. Like I've seen people who have had acute chikungunya that have difficulty just picking up a cup to take a drink or texting on their iPhones or something like that. So it is a prominent feature, and not only is the joint pain present during the acute illness, but it can persist for quite some time. So the statistics suggest that about 50% of people still have joint pain at 3 months after their infection. Symptomatically, there are a lot of similarities between these diseases, and also, as you mentioned, the mosquitoes that spread them are the same as well. So Aedes aegypti and Aedes albopictus are the key mosquitoes that spread these diseases. They tend to be urban mosquitoes. They can, particularly Aedes aegypti, hang around houses. So they can breed or lay eggs in trash that's lying in somebody's backyard, or a pot plant base, or an ornamental fountain, or sites like that. And basically, if you're in an area with either of these diseases, both of them can be picked up through infected mosquitoes. So the typical pattern with chikungunya virus transmission is often low-level transmission or even no evidence of transmission, and then very large outbreaks. And comparatively, dengue tends to be more of a disease where you see much higher levels of ongoing transmission. And as Ralph mentioned, there's 4 dengue viruses. So there can be various dengue viruses that are causing the ongoing transmission. With chikungunya, the outbreaks can be really explosive and really have a substantial impact. So, for example, I was in Paraguay last year during the early stages of an outbreak of chikungunya. Ultimately, there was about 140,000 cases that were notified during that outbreak, but about half of those occurred during about the first 6 weeks. And it was really hard to see the impact on health services. So there'd be long lines of people standing outside the hospitals waiting for to see a physician. So it really can have a substantial impact when these outbreaks occur.
So Ralph, all of us watched a lot of the Olympics and Paralympics, which were a fabulous athletic opportunity. But healthcare officials in Paris were quite concerned that there actually might be a dengue outbreak there during the Olympics. So can you comment on why they might have been concerned?
Yeah, and that is a very good question and important topic, because you'd say that these were typical tropical diseases and not really diseases that circulate in more temperate regions. However, we know that, we just discussed that dengue is a very widespread disease. It's the most widespread arboviral disease. So if you travel to a country, you can pick up the disease, but if you pick it up, you can also bring it back home. These diseases are on the rise, and it's closely related to the increasing distribution of the mosquito vectors that Susan just described. You referred to the Olympics and the Paralympic Games of this summer in Paris. So it was estimated that there were over the summer some 15 million. There's 15 with 6 zeros visitors visiting the France, and then there is autochthonous transmission that may be difficult, but it means that you get dengue in a non-endemic area without an appropriate travel history. So with 15 million people heading towards Paris and the French region, and with the huge dengue outbreaks going on at this very moment, the French health authorities were very concerned that visitors to the Olympics would bring the virus and start infecting the mosquitoes that live in France. It appears there have already been 82 cases of local transmission in France this year so far. And looking at Italy, where I have my academic affiliation, there were 199 cases reported, and even Spain in August and September had 8 cases of local transmission.
So, Susan, in places like Europe and the USA, why are locally acquired cases of dengue and chikungunya significant for public health, and what role do travellers play in the spread of these infections?
The concern is when somebody in the US who hasn't travelled has a diagnosis of dengue or chikungunya, they've picked it up from a local mosquito and these mosquitoes shouldn't be infected with dengue or chikungunya virus. So a single case is a concern. Even more concern is that there will subsequently be further spread. So, a local outbreak. So this year, for example, we've had in both Florida and California, local transmission of dengue. Of course, in the US territories, Puerto Rico, USVI, American Samoa, there's also a huge concern. And in fact, both United States Virgin Islands and Puerto Rico have got current outbreaks. If somebody gets sick with dengue or chikungunya or even Zika, the virus is essentially in their blood for about a week after they become sick. And if they use insect repellent during that time, it prevents them getting mosquito bites. Therefore, it prevents the mosquito picking up the virus and the opportunity for that to spread further. So we do really encourage travellers who are sick with either of these diseases to use the mosquito repellent for a couple of weeks to try and limit any risk of local transmission to the extent possible.
Yeah, and you mentioned earlier that these are mosquitoes that are well adapted to urban areas, so they can even be in cities, but they're also day-biting mosquitoes, is that right?
Yeah, that's correct. So they predominantly bite during the day, particularly dusk and dawn. And often people, when they're thinking about mosquito-borne diseases, particularly when they're travelling, they're thinking of the overnight biters, the ones that, they're using mosquito nets, for example, when they're in their accommodations to prevent malaria or something like that. But it is really important for travellers to be aware that these are, biting mosquitoes that bite during the day, and to be using mosquito precautions both day and night, so covering up with long sleeves, long pants, using insect repellent. If you're staying in accommodation, making sure it's something with screens or air conditioning, and really reducing the likelihood of being infected.
I think that's a little bit of a challenge. I think people hopefully are more cautious when they're traveling, but once they get home, if they get sick, if they're not sick enough to sort of be in bed where hopefully they won't get bitten, they really need to think about, like you say, protecting themselves from spreading the virus. All right, I'm going to ask a question of Ralph again. Just thinking about what we're doing to the environment, the changes in temperature that we're seeing around the world, how do you think that may have an effect on the spread of arboviral diseases like dengue and chikungunya?
That is a very important question, but also a very difficult one to answer. The host-seeking behavior, the feeding behavior of the mosquitoes is very temperature dependent. We cannot think of mosquitoes as flying syringes. It is the mosquito that takes a blood meal with viremic blood, so the virus is present in the blood, and it doesn't go to the proboscis, to the mouth. It isn't immediately set for transmitting the virus to another host, to another human being. But there is some time required where the blood is digested, the virus is moving through the mosquito gut, is moving through the hemocoel. That's what it's called. That's the yellow substance that you find on your windshields when you're driving late at night. And then it goes to the mouthpieces. So that whole process is called extrinsic incubation period. And that is also a very temperature dependent process. So at 25 degrees centigrade, there is excellent vectorial capacity, and at 20 degrees centigrade, it's a whole lot less. So our summers are getting hotter, are getting drier. The environment is getting more conducive for mosquito populations to propagate, and that is my answer to your question. Yes, climate is of influence, but we're left with a jigsaw, and we have a lot of missing pieces where it comes to explaining why in some parts of the world where the environments are conducive, where the mosquito populations are present, we do not see the surges as we're seeing, for instance, in Brazil or in Latin America at the moment. Why are we seeing such a surge in cases this year in 2024? There is some differences from year to year if you listen to climate experts, but it's not that marked as to explain the surge we're seeing currently in Latin America.
You know what you've said now. I've been playing Doomsday in Africa, saying, see what's happening in South America? This summer, we're in for it. Because what you've just said is, it's not just about getting hotter and blah, blah, blah. Is it unpredictable, or is it a matter of critical mass in how many people are running around with virus and then just enough mosquitoes and the right climate and then it happens?
Well, rest assured, LB, your continent will not be skipped.
Thank you.
No, as a matter of fact, there is a lot of dengue going on in Africa, and the problem is that the reporting has not been as good as, for instance, in Florida, where Susan will detect any single case that will present itself, and it will be analyzed. The trouble is that diagnosing dengue is more problematic than diagnosing a broken leg. If you in Africa see somebody by the side of the road with a leg in a very unnatural position, so you go like, oh, this guy could have a broken leg, and you don't even need an X-ray to make the diagnosis. But as Susan has pointed out, dengue is a febrile illness, and you have a lot of febrile illnesses in Africa, isn't it, Albie?
I'm absolutely convinced that dozens, if not hundreds or thousands, go diagnosed as malaria. And we don't want to miss malaria, but not every fever is malaria. And hordes of people come down with one of these viral diseases, get treated for malaria, get better, and therefore it must be malaria, but it isn't.
So there's a number of sites. Maybe we could provide some in a link to the podcast that give a bit of an overview of where dengue is being reported. And we see that the map of Africa is getting colored more and more. There have been outbreaks that have been highlighted, so it's there, and it's difficult to find out where exactly the reporting goes wrong, if it's not being recognized, or if the febrile illnesses are falsely classified as malaria or something else. But you do have the vectors, and you do have yellow fever transmission on your continent, which is a poster child for arbovirus.
I was just going to comment on chikungunya, which was first described in Africa, right? And the
Yeah.
name means to bend up, the classic sort of posture because of your severe arthralgias that are quite characteristic and even with inflammation with that arthritis with chikungunya. So given that history that it started there back, or was first recognized there back in the 50s, Susan, could you comment on maybe why Africa doesn't seem to have as much chikungunya as we think they would?
Yeah, so that's an interesting question. Clearly chikungunya has been in Africa for a long, long time. We first detected it in 1952 in Tanzania, but it was definitely there way before then. In Africa, one of the characteristic patterns of transmission is the sylvatic or jungle cycle. And in that cycle, the virus is circulating between non-human primates and canopy-dwelling mosquitoes. And humans get infected when they enter the forest for recreational, occupational reasons. So there can be sporadic cases. There'll sometimes be small rural outbreaks. They'll sometimes transport the virus to an urban area and you can have some urban outbreaks. But this sort of ongoing transmission has probably created over the decades has created some sort of background immunity among the population. I think another difference with Africa is just the lower population density in the cities, many of the cities. And then I think a third and clear factor is just surveillance. And by that I mean detection of cases and reporting of cases. So we actually hear about the cases that are occurring. And in many areas of Africa, there just simply isn't the diagnostic tests available to be able to diagnose the cases. And as Albie said earlier, I think it was there's so many causes of fever in Africa that knowing that a case is chikungunya without diagnostics can be impossible, basically. Potentially, the reason they don't come to as much light is there's potentially not the volume of travellers going to Africa and these locations like there is for travellers going to South America and going to Asia. So for travel medicine practitioners in particular, the traveller cases just don't occur at the same volume or frequency. And so, it's perceived as a less visible disease in Africa.
Yeah, I think it's relevant here as well that the incubation period for these diseases, so the time between getting bitten by a mosquito and developing symptoms, is typically short. So usually just a few days. So if travellers are going for many weeks on a trip and they get bitten by mosquitoes, it's likely that they might be unwell while they're travelling rather than presenting when they come back. Susan, you touched on the idea of immunity then, and I think that's maybe an important thing to discuss because it does to some extent explain some of the patterns that we see with these two diseases. Ralph, you before touched on the fact that there are 4 related dengue viruses. Susan, chikungunya, there's just one particular type of virus. Can you explain to us with chikungunya?
With chikungunya, there are 3 genotypes that are considered, but it's considered that they're essentially one with infection with one causing protection from infection from any of the other types.
And is that protection for life? So once you're infected, you're not likely to get infected again?
It's considered in general to be for life. There is at least one study out of Kenya that suggests reinfection with chikungunya virus, but overall, we don't really see reinfections.
So as you said, when it comes to a new area, you can have these really explosive outbreaks, and presumably that's because no one in the population has immunity. But then once most people have been infected, there's likely to be some years before you see another big outbreak in that area. Is that fair to say?
Yeah, so, and that's exactly what happened in the Americas. You know, after chikungunya was first identified in Tanzania in 1952, there was really just a period of 50 years where there were sporadic cases, small outbreaks. And then in 2004, the situation changed. We had the outbreak starting in Kenya, then subsequently spreading through the Indian Ocean, subsequently ending up in America. And that's when, at the end of 2013, we had the first detection of chikungunya virus in the Americas, and the huge outbreaks and spread through the Americas over the subsequent years, with ultimately about 2.7 million cases that were identified by the end of that outbreak. But yeah, that's definitely a factor, one of the factors, that is a reason for the nature of these outbreaks that can enter new areas where there isn't population immunity and really cause explosive outbreaks.
And so, Ralph, switching now to dengue. So you said there are 4 different dengue viruses. Can you get dengue more than once?
Yes, you can. As I told you, I think I had it twice. There is these 4 serotypes of dengue, and it's generally thought that after infection you develop immunity, initially cross-protective against all 4 serotypes, but the immunity to heterotypic infections wanes after 5-6 months. If you have homotypic immunity to one of the serotypes of dengue, there is a school of thought that thinks that it not only doesn't neutralize new heterotypic dengue virus infections, but it predisposes to more severe disease. So it's not only non-neutralizing, but it's aggravating.
I think, like you said, it's a really complex area, isn't it? And immunity to dengue is complex. And I guess to try and simplify it for our audience a bit, as you said, when you first get a dengue infection, you develop immunity to all dengue serotypes, so all 4 dengue viruses, but you only develop long-lasting immunity to the one that you're infected with, and the immunity you develop to the other serotypes is not long-lasting, and in fact it might make you more likely to get sick with dengue that second time you get dengue. And so the vaccines really have the most benefit in people who have had one dengue infection, who are at risk of being infected a second time and getting severe dengue. Is that a fair way to put it?
Sums up the question. And that has been a great challenge in the development of dengue vaccines. Although I'm looking forward to hearing the results of the analysis from the use of the TAC-003 vaccine that was developed by Takeda Vaccines, and it has been donated. 5 million doses have been donated to the Brazilian authorities to combat the ongoing outbreak in Brazil.
Ralph and Susan, that's really interesting that you talk about immunity and vaccines and the availability for these endemic populations. What about on the front for travelers? Are these vaccines going to be available for travelers? And does it make sense to have these vaccines for travelers at this point in time?
Great question, Aisha. So this particular vaccine is registered under the name of Qdenga, and it's been registered in Asia, in Thailand and in Indonesia. It's been registered for use in travelers in Europe, but there is a lot of discussion ongoing on whether we should advise our travelers in the travel medicine community to take the vaccines, precisely because we do not really know that it's protecting. But we do have a good sense that the TAC-003 is protective against serotypes 1 and 2. And then another complicating factor is that that the reimbursement of the vaccines by health insurance or by government is very, very different to non-existent in some parts of the world. That even goes for Thailand, where dengue is hyper-endemic. I was talking to my colleague Wasim Matsi earlier today, and he said, yeah, people just have to pay for the vaccine. So even in endemic populations, it's a problem. So that brings me to the final consideration that I would like to share with you. How ethical is it really to try and protect travelers who do have a risk? But I think in comparison to people who live in endemic areas who have perennial risks, if there is an effective vaccine, I think this is a whole different discussion, maybe a little bit outside the scope of what we're discussing today, but still, health economics, always very difficult.
The Qdenga vaccine you mentioned, it's 2 doses 3 months apart, am I right?
Yeah. Yeah.
So if someone comes to see you and they're leaving in 2 weeks, you don't have the opportunity to give them 2 doses of the vaccine.
I think the final word there is also not out yet, because if you look at the returning travelers with severe dengue, so that is the travelers that do develop organ damage, organ complications, organ failure, plasma leakage, these are not all secondary infections. So we should really not think of primary infections as first time, no problem, and watch out for your second infection. And as I have tried to illustrate in my personal case, you can have had a dengue infection without even knowing it. So yeah, that makes testing the only way to really find out if you've been infected before.
Susan, I might come over to you now. So there's also been a new vaccine for chikungunya released in the last year. And unlike the dengue vaccine, it's a single dose vaccine. Can you tell us a little bit about its introduction in the US and how it's being used?
So, as you said, the first chikungunya vaccine to be licensed globally was licensed last year in the United States. And in fact, it's since been licensed in Canada and in Europe, although I believe that right at this time, it's currently only actively being distributed in the United States. And as you said, it's a single dose, and the early data do suggest that single dose probably gives many years of protection. So that's very encouraging. And the primary recommendation we have made for its use is for travellers going to an area with an outbreak. So, for example, as I've mentioned, Paraguay had an outbreak last year. Paraguay is not a popular destination. Fewer than 1% of US travellers travel to Paraguay, but among all our chikungunya cases last year, 25% of all the travellers had been infected in Paraguay. So it just really emphasises that risk during an outbreak. And that was really brought home for me when I was there as well, because, I was going there to work alongside the Ministry of Health to help respond to this outbreak. So I was very careful. I was, wearing long sleeves, long pants, using my insect repellent, very carefully. I was going through about a bottle a week while I was there. And yet during the time that I was there, I still got mosquito bites, despite all those efforts. So, it really just reinforced for me, if there had been a vaccine and I was going to an outbreak area, I definitely would have gotten that vaccine. The other thing to mention is that there is a second chikungunya vaccine that has been submitted to the US FDA for licensure and also elsewhere. It's a different type of vaccine. So the currently available one is a live attenuated vaccine, which essentially means it's based on a sort of a weakened virus. The new vaccine is a virus-like particle vaccine. So this virus-like particle is essentially very similar to the virus, but it has no viral genetic material, so it can't replicate. And we are anticipating that this vaccine might be licensed as early as February next year, which would mean 2 vaccines available. And in fact, this second one would be potentially licensed for 12 years and older. So it would mean we'd have vaccines that sort of cover a younger age group as well.
Yeah, I think the trick, as you say, the risk is higher where the outbreaks are, but then how do we know when there's going to be an outbreak and which travellers we should be vaccinating?
It's a good point. Fortunately, there is fairly rapid immunity after that dose. We do at CDC monitor very closely. So, for example, we're gathering information on a daily basis through event-based surveillance and our traveller data, and with interactions with the World Health Organization. And we do actually have a website where we post notices and information if there is an outbreak, and we can probably include that in the links for this episode for people's awareness, so you can go to that page and see if there is any outbreak notices. But as you said, it's a challenge because not every location that has an outbreak has the capacity to test and report in a timely way.
Yeah, so that sort of just made me think again about the sort of comparison that Ralph mentioned in bits and pieces about yellow fever. We eat, sleep and drink yellow fever in South Africa in travel medicine because it's an international health regulation requirement from our Port Health to come back, because we don't want you to bring yellow fever to South Africa because we've got the Aedes mosquitoes. So if that's still considered an effective control method for yellow fever, why would we not do the same for 2 other viruses that are transmitted in exactly the same way and pose perhaps even a bigger acute risk for the foreseeable future? And Ralph, I see you scratching your head, so that was a sign that you'd love to answer the question. Should proof of dengue and chikungunya vaccination become regulated by the international health regulations, WHO?
He's opening up a can of mosquitoes. That's what he's doing.
That's what I'm here for.
He's opening up a can of mosquitoes.
There was a suggestion earlier on that we should talk about sex because you talked about Zika, but that's not allowed. So I'll ask about the international health regulations. The idea that you should use insect repellent after you return from a journey to prevent you spreading the virus is a little bit like using condoms after you'd been to a Zika area.
Yeah, so do you want me to take this on, Albie?
Yes. You don't have to answer the one about condoms, but please reply about the one on international health regulations and dengue and chikungunya.
Well, maybe there's some comparison there, because I do recommend you to use condoms, but it doesn't do any good to protect you against dengue or chikungunya. If you have antibodies to yellow fever, then you are considered protected. Most people now accept that you're protected for life. Mortality rates of yellow fever are really incredibly high, so often above 30%, even with good care. That is definitely not the case for dengue or for chikungunya. My gut feeling says that that is not really a very cost-effective intervention. If you check for chikungunya, you can detect antibodies, and you can detect antibodies after being vaccinated or after infection, and that correlates with protection. For dengue, this is not the case. Also, we do not have routinely available antibody testing that discriminates between antibodies as a result of your vaccination or prior infection. Now, you might want to adopt a policy that you keep out anyone with antibodies against dengue from visiting you, Albie, but I think you'd be a very, very lonely person in South Africa.
Yeah, well, that's an interesting thing to say, because from the South African perspective, dengue is it's a scarce disease. But thank you for your answer about the chikungunya. It doesn't matter that much, and dengue, we just have to clean up our water containers everywhere, which is a tricky one.
Well, I think given the international threat, like it's interesting to talk about and mention other potential innovations and other technologies that can be used, including cleaning up, local water containers where maybe risk for breeding sites for mosquitoes. But I know, Sarah, you've actually had some interesting results in Australia. So is there something you could comment on in regards to future innovations?
Sure. Yeah, I mean, it's a good segue from what Albie was just talking about, which is the kinds of diseases that we see in our countries are shaped by the travel destinations that our travellers go to. Here in Australia, our travellers often go to Asia and the Pacific. So we don't see many cases of malaria in return travellers because we don't see as many travellers to Africa, but we see many, many cases of dengue in our return travellers.
The malaria cases die in Africa. Don't worry. That's why you don't see them.
That's a one-way ticket then, Albie.
Oh.
Because of this frequency of how much we see of dengue, we were seeing lots of outbreaks of dengue in particularly North Queensland that was started by returning travellers. And although dengue's never been endemic in Australia, there were so many outbreaks that we were seeing many cases. And Susan knows about this because she used to work in that part of the country. But one innovation that came out of the lab was this discovery that a bacteria called Wolbachia, which is actually a bacteria that comes from a fruit fly, injected into mosquitoes, actually reduced their ability to transmit viruses in the lab. And then this was then taken to the field, and they were actually able to release these Wolbachia infected mosquitoes, or the Wolbachia carrying mosquitoes. And they saw that those mosquitoes weren't really capable of transmitting dengue. And added to that, they could actually overtake the normal mosquito populations, because when a Wolbachia mosquito bred with a non-Wolbachia mosquito, their offspring wouldn't hatch, or they would be carrying Wolbachia bacteria, depending on the pairings. And we haven't seen an outbreak of dengue in North Queensland for some years now. And it's really exciting. It's only been done in Aedes aegypti mosquitoes, but it has been rolled out in various parts of the world. And the World Mosquito Program that delivers this technology has partnered with many other countries, including in Asia, in Fiji, in parts of South America. And they've delivered this intervention across a lot of settings and had some really successful results in field testing. So it's very exciting. One thing about it, I think, is it's counterintuitive to everything that we do for public health control of mosquitoes, because the intervention, so, the way they solve the problem is to release mosquitoes and let those mosquitoes overtake the local mosquito population.
So she's literally opening up a can of mosquitoes in Australia.
I just wanted to know whether one can infect politicians with Wolbachia.
That I don't know about, Albie. I think you might have trouble getting an ethics application up for it.
We're hearing a lot about the Urupuche outbreaks now in Central America. Ralph, could you comment on that a little bit about what's going on, what we're going to be seeing maybe?
Yeah, so Urupuche is just one of many viruses that is transmitted by arthropods. But it's a very, very different virus from both dengue, which is a flavivirus, and from chikungunya, which is an alphavirus. Urupuche also can lead to febrile disease. So just like dengue and chikungunya and a number of other viruses, clinically it may be very, very difficult, if not impossible, to tell them apart and to diagnose Urupuche. You need laboratory support. The virus has been among us for 70 years, but it's transmitted by midges, biting midges. I think in the United States they call them no-see-ums because they're very, very small. And I was told by an entomologist that there is over 1,300 species of midges, of biting midges, and not all of them are capable of transmitting Urupuche virus. So this may be a reason why the the distribution of Oropuchi up to now has been confined to Latin America, but only in this year we're seeing that for the first time really the number of cases is increasing. So there's approximately 10,000 Oropuchi cases so far in 2024. We generally think it's a very mild, self-limiting febrile illness. Until this year, no fatalities reported. But this year, and this may be a numbers game with the 10,000 cases, there were 2 deaths. These deaths were among healthy young women in their 20s. And we also are only beginning to understand the complicated protective immunity that results, or immunity that results, and is not always protective to other serotypes of blue tongue virus. So this may also be the case for Oropuchi, with these parts of genome reassorting and resulting in different phenotypes. Yeah.
So an area that definitely is being monitored, and we'll be watching this space, but
Yeah.
not releasing any cans of midges anytime soon.
No.
So, just to wrap up, what would be your top 2 or 3 key take-home messages for travelers listening today?
We've talked about dengue, we've talked about chikungunya today. We've talked briefly about Oropuchi just now. There are many diseases spread by mosquitoes, midges, in some locations, ticks. Packing the insect repellent, packing clothes to be able to cover up, long sleeves, long pants as possible. Clearly it's often hard in hot areas to be covering up, but just be aware that these diseases, aren't minor in some cases and really can have severe outcomes. So just remembering those basic principles of protecting against mosquito bites, even if you have been vaccinated. No vaccine is 100% effective, so still taking those measures to protect against mosquito bites. I would also add, for any travel medicine physicians that are listening in, or healthcare providers, remembering to actually do some diagnostic testing. We often have travellers who come back from overseas and they have some joint pain and they're given a diagnosis of chikungunya without actually having a blood test done. And what we don't want to do is miss some other serious diagnosis, the first presentation of rheumatoid arthritis or psoriatic arthritis or something like that just happens to occur in conjunction with their travel. So I think that's another important message. And really, the final message is expect the unexpected. We really don't know what's going to happen next, where it's going to happen. And it's fascinating, concerning, but watch your space for what's coming next.
Susan summed up nicely what is important. I think one thing that is really important to recognize for travel medicine practitioners, but for general practitioners, for anyone who sees returning travelers, is to take the incubation periods into consideration. Most of these diseases will primarily present as febrile illness, and especially if somebody develops a fever within 2 weeks after returning from their travels, think that it might be something else than your local flu. And if you are in doubt, consult colleagues or laboratory facilities in your vicinity that can help you out in working out, doing the clinical workup of your differential diagnosis, which should include these knowns and unknowns. Yeah.
And yeah, I'd just like to add, I think it's been a fantastic discussion of these 2 really interesting diseases, dengue and chikungunya. These are really important diseases for our travellers to know about, but obviously they're just 2 of many diseases spread by biting vectors. And I think we heard that travellers, these diseases can affect them and they can be really serious, but travellers can also bring them back to their home countries and really create a public health problem where they're living. So it's really important for travelers not just to be conscious about covering up against mosquito bites when they're away, but also when they're back, and particularly if they get sick, to see their health provider to make sure they get a diagnosis. And if they do get a diagnosis, to be covering up against mosquitoes so that they don't infect the mosquitoes that live near them and create a problem for other people in their area.
Great. Well, thank you so much for all our expert guests visiting from all over. So we've got Italy, we've got Fort Collins in the US, we have Albie joining us from his farm in South Africa, and Sarah from Melbourne, and myself from Edmonton, Canada. So thank you again for joining us for this episode of Travel Unraveled. We will have links to all the resources that were mentioned in the link section for the podcast. Do subscribe and give us feedback as well. We always love to hear from our listeners. And until next time, use your bug spray and don't get bit.
Thank you to our sponsor, the International Association for Medical Assistance to Travelers, located on the web at iamat.org. Don't forget to follow Travel Unraveled on Spotify and on Apple Podcasts or on your favorite podcast platform. We'll post fun clips and extra resources on the ISTM website located at learning.istm.org/podcast. We're also on Facebook, LinkedIn, X, and Instagram at _ISTM_. Travel Unraveled is brought to you by the International Society of Travel Medicine. Finally, and thankfully, Travel Unraveled is produced by Ghost Bureau out of Toronto at ghostbureau.com.
Please remember that the information presented in this podcast is intended for educational and informational purposes only. It should not be considered medical advice, nor is it intended to replace consultation with a qualified healthcare professional. The views expressed by the host and guests of this podcast are their own and do not necessarily reflect the opinions or policies of the ISTM or any medical or other health professionals, hospitals, clinics, or healthcare facilities. While we strive to provide accurate and up-to-date information, the medical field is constantly evolving, and there may be new findings or developments not included in our content. We encourage our listeners to consult with their healthcare providers for any medical concerns or before starting any new treatment. Neither the ISTM nor any of its affiliates, sponsors, producers, hosts, or guests are liable for any direct, incidental, consequential, indirect, or punitive damages arising out of access to, use of, or inability to use the content of this podcast, or any errors or omissions in the content hereof. By listening to this podcast, you agree not to use this information as a substitute for, nor does it replace professional medical advice, diagnosis, or treatment. Always consult with your healthcare providers for guidance appropriate to your specific health situation. Thank you for listening to Travel Unraveled. We are committed to sharing knowledge and fostering discussion in the pursuit of better health and well-being.